and today I'll be presenting our paper investigating why clinicians deviate from standards of care, liberating patients from mechanical ventilation in the intensive care unit. Mechanical ventilators save lives in the intensive care by taking over the work of breathing when a patient can't breathe on their own. However, staying too long on a ventilator can be really harmful. For this reason, clinicians try to get the patients off of ventilators as soon as possible. They use the Wake Up and Breathe protocol, an evidence-based guideline, to assess if a patient is ready to be liberated from a ventilator. This protocol has been very effective in reducing the average number of days a patient remains on a ventilator and decreasing mortality. Unfortunately, the protocol is often not followed in clinical practice. So the protocol is performed by nurses and respiratory therapists. First, a nurse performs a spontaneous awakening trial, SAT. They cut off a patient's sedation to observe if they can tolerate being awake. Next, a respiratory therapist performs a spontaneous breathing trial, SBT. So they cut off the ventilator's breathing support to observe if the patient can successfully breathe on their own without the mechanical support. So these two sequential actions must ideally happen before the patient rounds so that, based on the result, the care team can decide if a patient should be liberated from a ventilator. And nurses typically provide care for 1 or 2 patients, while respiratory therapists provide care for all patients in an ICU. So they need to carefully orchestrate their actions to perform this protocol. Prior research in medical literature identified a number of barriers to the execution of the protocol. So they found that nurses often don't want to cut sedation because patients get anxiety. Clinicians may not know about the protocol, or it may not be performed due to high workload. And researchers also note that there are challenges in coordination and collaboration. And they speculated that team members would be more likely to adhere to the protocol if they could predict the actions of each other. So building on this line of work, we set out to investigate why clinicians deviate from the Wake Up and Breathe protocol. Specifically, we wanted to understand the clinical workflow around SAT and SBT, and we wanted to identify opportunities for AI systems and computing technologies in general to support clinicians in performing SAT and SBT and clinical protocols in general. So we conducted a field study in 3 intensive care units across 3 hospitals. This included observations, one-on-one interviews, and group interviews with nurses and respiratory therapists. We recorded and transcribed these sessions and analyzed them using thematic analysis and affinity diagramming. So our fieldwork showed that, unlike what literature suggests, clinicians do not consciously avoid executing the Wake Up and Breathe protocol. So there were instances where the protocol was not performed, and the reason was there were a lot of uncertainties regarding a patient's eligibility to receive the protocol and regarding the execution of the protocol. So when clinicians face uncertainties, they prioritize high certainty tasks, which meant that the protocol was deprioritized or postponed for some patients. So it was almost like procrastination rather than non-compliance. We mapped out many points of uncertainty before, during, and after the execution of the protocol. So for instance, there were uncertainties around which patients should receive the protocol or which patients should have priority. Additionally, it wasn't always clear when SAT and SBT should be performed or how to coordinate with nurses and respiratory therapists. Finally, when we probed clinicians about the use of electronic health records, they shared that the EHR doesn't guide them through the steps of the protocol. Instead, it seemed to hinder the protocol by separating the actions into checkbox tasks for nurses and respiratory therapists, which sort of reinforced individual accountability rather than coordination. Moreover, clinicians shared that there were cases where they would get penalized because of the way protocol was structured in the EHR. For example, they did not get credit for performing the protocol if it was postponed to be done later in the day. So moving forward, we see a great opportunity for HCI researchers to support clinicians in performing protocol-based care, and this includes supporting clinicians in assessing patients' eligibility and supporting them in adapting clinical guidelines to their context. And additionally, we should design systems that support unit-level coordination to help clinicians perform interdependent protocol actions. Part of the challenge is the way we talk about adherence. So medical literature often assumes that clinicians ignore these protocols, framing them as negligent or non-compliant. But our research showed that this is not the case. Clinicians are pretty overwhelmed, so they prioritize high certainty tasks. So we see an opportunity to reframe what protocol adherence means in the clinical setting. And this could open up new directions for supporting the performance of collective delivery care through service-oriented design to allocate clinical efforts more efficiently and fairly across many patients to maximize outcomes for all. Finally, our work shows that there are opportunities for AI systems to support coordination across clinicians. For example, systems can identify which patients might be eligible for a protocol, and they can present a prioritized patient list to help clinicians perform the protocol. So future research should explore how such systems could be situated in clinical workflows, specifically to understand issues around user agency and acceptance. For more information on this work, please see our full paper. Thank you.